first, this sounds like a hospital bed problem. A person is well enough to leave. The doctors no longer need to keep them in an acute ward. Someone else may be waiting for that bed, but the person is still there. The missing medicine is not inside the hospital, it is a door key. Social workers are warning that homeless mental health patients should not be kept in hospital longer than needed and should not be sent into unsuitable temporary housing. Health New Zealand says it can take days or weeks to organise accommodation. It also says some people may be discharged to transitional housing, boarding houses, or motels. That one detail opens a bigger New Zealand story. Mental health care does not end safely when a person is clinically ready to leave. It ends safely when there is somewhere stable enough to continue living. Hospitals are built for crisis. They can keep someone safe during an acute episode. They can provide assessment, medication, nursing care, meals, routines, and a locked or closely managed space when that is needed. But hospitals are not homes. A hospital bed has a clock on it. It is needed by the next person in crisis. It is staffed by people working shifts. It is expensive. It is not where most people rebuild a life. The old hope in modern mental health care was that people would not spend years hidden away in institutions. Care would move closer to the community. People would live ordinary lives with support around them. That idea is humane. It is also fragile. Community care needs a community. It needs a room, a tenancy, a support worker, a general practitioner, transport, food, money, family if family is safe, and a place where sleep is possible. Without those things, discharge becomes a word on paper. It does not become a safe life. Housing can become part of mental health treatment even when it does not look medical. Think about the first night after hospital. Where is the person going to sleep? Will they be alone? Can they take their medication without losing it? Can they store food? Can a support worker find them? Is there a phone charger? Is there a door that locks? Is there a neighbour, a landlord, a staff member, or nobody at all? These are not small details. They are the difference between recovery and another crisis. New Zealand law already understands this in one important place. The Mental Health Compulsory Assessment and Treatment Act 1992 allows compulsory treatment orders to be made as community treatment orders or inpatient orders. When a court is considering community treatment, it must be satisfied that outpatient care is appropriate and that the person's social circumstances are adequate for care in the community. Those words matter. Social circumstances. The law is saying that treatment is not only a clinical question, it is also a living situation. Not every person in today's story will be under that law, but the principle is wider than the law. A plan only works if the world around the person can hold the plan. This is where New Zealand's health system meets its housing system. If there is no suitable home, the hospital can become a waiting room for housing. If the hospital discharges too quickly, a motel or boarding house can become a weak substitute for care. If the place is unsafe, noisy, isolated, or unstable, the person may return to crisis. Then the hospital sees them again. This cycle is painful for the person. It is also painful for the system. One person stuck in hospital longer than needed means one bed is not available for someone else. One unsafe discharge can lead to another emergency visit, another ambulance, another police call, another family crisis, another night when nobody sleeps. The problem looks like pressure on the health system, but part of the pressure may be outside the hospital walls. New Zealand has a serious housing shortage at the lower end of the market. The 2023 census severe housing deprivation estimate put the number at about 112,500 people, around 2.3% of the population. That includes people without shelter, in temporary accommodation, or sharing housing in severely crowded situations. Those numbers are not all mental health patients, but they show the size of the ground that mental health services are standing on. When housing is tight for everyone, it is even tighter for people leaving crisis care. A person may have no rental history, they may have debt, they may have burned relationships, they may need a place that is sober, calm, safe, and close to support. They may need staff on site. They may need a landlord willing to take a risk that other landlords will not take. The market does not naturally create many homes like that. The result is that charities, social workers, community housing providers, Maori and Pacifica services, Health New Zealand, councils, and government agencies all end up in the same story. Nobody owns the whole answer. Everybody owns a piece of the failure when the answer is missing. There is a hard truth here. A motel room can be better than the street. It can be warm. It can have a bed. It can give someone a short pause. But a motel is not the same as a recovery plan. A boarding house is not always the same as safety. Transitional housing can help, but the word transitional only works if there is somewhere to transition to. If the next step is not real, the temporary step can become another trap. For the public, this issue can be easy to miss. People see hospital delays as a health problem. They see homelessness as a housing problem. They see mental illness as a personal or family problem. For the person leaving a ward, those are not three problems. They are one morning. They have one bag, one discharge paper, one set of pills, one phone call to make, one address or no address. The system may separate the files, life does not. That is the part worth remembering. When a person is stuck in hospital because there is no safe place to go, the hospital is showing us a housing failure. When a person is sent to a place that makes recovery harder, the housing system is showing us a health failure. Neither system can pretend the other one is outside the room. The practical test is not complicated. After discharge, can the person sleep safely for the next 7 nights? Can support find them? Can they keep appointments? Can they avoid the people, places, and pressures that helped push them into crisis? Can they stay long enough in one place for ordinary routines to start again? If the answer is no, then the discharge is not really finished. New Zealand often wants public services to work as separate doors. Go here for health. Go there for housing. Go somewhere else for income. Fill in this form, wait for that call. But recovery often needs one joined-up doorway, not a perfect life, not a luxury apartment, not a promise that nobody will ever struggle again, just a real place to begin. Hospital pressure and homelessness are often the same story seen from different ends of the corridor. Sometimes the most important treatment after a mental health crisis is not another night in a ward. It is a safe place to unlock in the morning.